Recording.
Good morning. Welcome to our improvised class today. I'm sorry that you can't be here with us in the PSC, but today we're going to discuss endocrinological emergencies.
Say that fast 3 times.
No, thank you. So we're going to start today with a little bit of anatomy and physiology of the endocrine system. Most of us probably haven't talked about in the anatomy and physiology since we were in EMT or paramedic school. We're going to do this from a 10,000 foot view, so we're not going to be too in-depth, but we do need to discuss some important concepts. So the endocrine system is a network of glands. They produce and secrete hormones. And these hormones go directly into the bloodstream. So these are ductless glands. They're secreted into the bloodstream, they go to their target organs, and then they work. The whole goal of the system is to maintain homeostasis. We want to maintain that even keel, much like our pH, we want to maintain that very specific balance of the body. And these hormones do promote permanent structural change. When we start talking about things like growth hormone and some of the other hormones, they do promote permanent structural change within the body. So there are many endocrine glands within the body. Today we're going to be highlighting the 8 major endocrine glands. The first being the hypothalamus, the pituitary, the thyroid, parathyroid, thymus, pancreas, the adrenals, and the gonads. So the hypothalamus is located deep within our brain. It's a collection of tissue that sits just above the pituitary gland and ahead of the brain stem. It's located within the cerebrum. It's in response to impulses from the autonomic nervous system and other organs. It does release its hormones to promote the homeostasis. They act almost exclusively upon the pituitary gland and in control of other hormones. This, though, the hypothalamus is the link between both the endocrine and the nervous systems. The pituitary gland, also known as the master gland, is links, as we said, with the hypothalamus. This can be divided into 2 areas. We have the anterior and the posterior pituitary gland. If we look at the anterior pituitary gland, this is where the majority of the endocrine functions do occur. We have functions within the gonads, within the kidneys, the thymus, growth hormone, as we talked about earlier, some with skin, some with the mammary glands. And then on the posterior aspect, we also do have some mammary glands, some uterine hormones, and then we have hormones that act on the kidney. The posterior lobe, like we said, responds to those nerve impulses. It secretes antidiuretic hormone, which is one of the major functions it does, which results in retention of body water. So this is very important for us when we're talking about maintaining homeostasis, maintaining our blood pressure. There was actually some literature that I was reading that patients that achieve ROSC actually have higher rates or higher measurable levels of the antidiuretic hormone in their blood chemistries. The anterior lobe is the hormones, as we talk about, that target the other glands. There's that multitude of them that we discussed. The thyroid and the parathyroid sit on the trachea, sit just below the cricothyroid membrane. For us paramedics, we know that our thyroid cartilage, our cricothyroid membrane sits right here. This is very important. We talk about making sure that we have that vertical incision as we do our cricothyroidomy, as opposed to that horizontal, because this does sit on either side. This is a very vascular area, so we have to make sure that we are very careful when we're doing that procedure. The parathyroid glands actually are on the posterior aspect. There are 4 of them, and they sit at the inferior base of the thyroid gland. The thyroid, again, located anterior to the neck, inferior to the larynx. It secretes calcitonin, which lowers our blood calcium levels. Triiodothyronine, or T3. If you're in the hospital, you may hear a T3. Free T4 is a lab value that sometimes that they will look at. It also stimulates cell metabolism, and thyroxine, or T4, also stimulates cell metabolism. The parathyroid, on the posterior, as we discussed, secretes the parathyroid hormone, which increases blood calcium level. Now, calcium becomes an important part. Calcium plays, it's a cation, so a positively charged particle, plays an important factor in blood clotting, heartbeat, and most importantly, in neuromuscular initiation. Our thymus, located in our chest, on a fetus, if you note, the thymus right here is very large. However, as we age in adults, the size decreases. The thymus is very important because it helps with our immune response. It's active during the childhood, it's maximum in its size during puberty. It helps identify and destroy foreign intruders. It secretes thymosin, which promotes the maturation of T cell lymphocytes. So when we talk about the immunity system, we have helper T cells, killer T cells. That's all part of the process that we have to fight off infection. So this is an important gland as we're growing that helps keep us healthy. Probably the most common gland when we refer to the endocrine system that people think of is the pancreas. With most of our medical emergencies that we run on when we talk about endocrinological are going to be our diabetic emergencies. It's that fish-shaped organ, sits just above the stomach. As you can see here, it secretes right into the body here, the pancreatic ducts, the bile duct. This becomes important later. This bile duct can create some problems for us in one of our medical emergencies that we see and may not think about as often. There are 3 cells actually, specific cells in the islets of Langerhans. The alpha cells, beta cells, and delta cells. We're going to talk about the alpha and beta cells. Alpha cells secrete glucagon. That stimulates the breakdown of glycogen, and it increases our blood glucose levels. If you remember, we give a medication called glucagon when we can't give IV access or we can't have them take in oral glucose. That the glucagon stimulates changes the glycogen stores in the liver into sugar, so that helps us when we have those patients that we can't get access on. Our beta cells, high blood glucose levels stimulate the production of insulin, which facilitates glucose transport in the cell. Remember, the insulin and glucose are like lock and key. We may have glucose floating around in the cells, but without the insulin to get into the cell, it can't go anywhere. So that's why beta cells are a very important part of this process. It also helps facilitate metabolism, and this promotes glycogen stores, formation of glycogen stores in the liver. Pediatric patients, however, don't have the glycogen stores. It's not very effective for them, so they don't have those well-developed stores. Glucagon may not work effectively on our pediatric population. We have our adrenal glands. They sit right on top of the kidneys in the retroperitoneal space. They have 2 parts. We have the cortex and the medulla. The medulla, located on the superior surface, responds to impulses from the autonomic nervous system. This is what secretes our epinephrine, our fight or flight response. So again, part of the hormones that are released, I'm facing a threat, I get that stimulation, it secretes epinephrine. Now I have the things like increase in heart rate, bronchodilation, dilation of the pupils. I'm now ready to fight or I'm ready to run. It also secretes norepinephrine, which helps with vasoconstriction. If I'm wounded, I have that vasoconstriction property going on, hopefully going to staunch some of the bleeding that may occur. The adrenal cortex has glucagon-like effects. It's also an anti-inflammatory and immunosuppressive agent. They also secrete mineralocorticoids, which help contribute salt, so that's maintaining part of our fluid balance. Remember I said earlier that that's an important part of the system, is maintain that fluid balance throughout the body. And they also have some androgen hormones which have some similar effects to that of the gonads. In our females, the ovaries are the organ that we refer to with the endocrine system, the gonads. There's a lot of actions that occur with this, particularly when we're talking about fertilization of eggs, implantation of egg as part of the pregnancy process. In males, the testes, located in scrotum, produce sperm. Estrogen, which is secreted, also helps with secondary female sex characteristics. As we talked about, or as I mentioned, that we have egg development before we have ovulation. Progesterone, which is helps with the implantation of the egg, maintenance of the lining. So we want, as that egg is implanted, we want that to have a good lining. We want that to become a healthy fetus as it grows. And then it also secretes small amounts of testosterone, which helps with changes with puberty. The testes, which again come from the anterior pituitary glands we mentioned earlier, promote development and maintenance of the secondary sex characteristics and the development of sperm. So we're going to talk about some pancreatic emergencies and some of our management. Diabetes is the one that we think about. Diabetics are our bread and butter call that we see. There's approximately 34.2 million diabetics, or 10.5% of the entire US population, that has diabetes. 7.3 million, or about 21.4% of adults with diabetes, aren't even aware of their diagnosis. Sometimes we will get called for someone who's unresponsive. We check blood sugar and their blood sugar is elevated. Well, they don't have a history of diabetes. Well, they don't have a diagnosed history of diabetes. I have a good friend of mine who last week, his wife had a medical emergency, unfortunately, wound up in the ICU. He called, he let me know about all this. I was pretty concerned. I was asking some questions about what happened, what was going on. He told me that her sugar was 300. Well, among my differentials of things that I'm going through, I'm worried about neurologic emergencies. She had recently had influenza, so I'm worried about sepsis because they'd also told me she was tachycardic, hypotensive, a lot of things going on. Come to find out, her blood sugar is actually over 700. So one of the first things that I thought was diabetes. In her case, what they believe is the underlying infection that she had. They had started her on some steroids, which caused a spike in her blood sugar. She had previously undiagnosed diabetes. When he found her, she was actually diabetic ketoacidosis. Fortunately, he called me yesterday. She's actually doing much better. Has been moved out of the ICU. Timely incident to illustrate the point of undiagnosed diabetes in our populations. 88 million adults over 18 years of age are 34.5% of our population, adult population, have prediabetes. So prediabetes, there's actually some formulas that they use. They look at your blood sugar when you're fasting to see if you're above a certain point or not. One of the other things, you've probably heard of the hemoglobin A1C that they actually test. And there are some criteria that they use for those. Again, pre-diabetics, if maintained, may not develop fully into diabetes if we do things like diet and exercise, but these are patients that are at significant risk. As far as our emergency, the EMS and ER, diabetics account for 16 million ER visits with any kind of diabetic diagnosis. So it may be a primary or secondary diagnosis. 16 million ER visits a year. It's the seventh leading cause of death, and the latest number I had was from 2017, seventh leading cause of death. That has not changed. I looked at some previous lectures that I had done on this subject, and about 5 years ago, it was still hanging out at number 7. One of the real impacts that we have, though, $327 billion in both direct and indirect costs. This disease has a lot of complications, as we know. We see those patients. It's a significant cost to our population. So when we talk about diabetes, most people think, oh, type 1, type 2, that's what we learn. And yes, that is correct. Juvenile onset or insulin-dependent diabetes accounts for 5 to 10% of the population. It's thought to be closely related to heredity. There's some questions about how this actually occurs, but heredity is a leading thought. Environmental factors may also be part of this. This is characterized, we have that low production of insulin. So these are the patients that have to give themselves insulin on a regular basis because their body does not make insulin or does not make enough insulin. When we talk about insulin, we don't give insulin. We may see our patients that get insulin either as a medication that they administer themselves or through an IV pump. I did a little bit of background because I didn't know that much about the insulin other than it was there. There's actually 5 types of insulin primarily that we talk about. Our rapid-acting insulins works in about 15 minutes once it's injected. It peaks at about 1 hour and it lasts 2 to 4 hours. Most common ones that with rapid-acting are Humalog and Novolog, which we see quite often. Our regular short-acting takes about 30 minutes to start to work. It peaks in 2 to 3 hours, continues working for 3 to 6 hours. That's our Humulin and our Novolin. Our intermediate starts working in 2 to 4 hours. It peaks at 4 to 12. It works for a while. It works 12 to 18 hours. Okay. Humulin, Novolin, N. Sorry about that. Then we get into some of our longer actings. So the long acting reaches the bloodstream several hours later. It lowers glucose for up to 24 hours. That's a significant time frame that works. Lantus and Levemir are the most common ones that we'll see. And our ultra long actings, it takes up to 6 hours to get into the bloodstream. It doesn't peak and it lowers blood glucose for 36 hours. For a day and a half, those medications will continue to work. Some of these are newer ones, Toujeo and Tresiba. There's a lot of new ones that are coming out on the market all the time, so I encourage you, try and keep up on those when you see those new medications that you don't recognize for diabetics. Some of our patients are now wearing insulin pumps. These are pretty cool. When I started in EMS, these were really kind of in the infancy. We didn't see a whole lot of them. They've gotten much smaller now. There's really 4 to 5 main components. It depends on your patient. You're going to have your insulin pump. Small now, they're about the size of a pager for those of you that remember pagers. They're pretty small. You have an infusion set, so it inserts a plastic cannula just under the skin. No needle, plastic cannula. You've got the reservoir which goes into the insulin pump. So this contains your insulin, depending on your physician, what they write. Most of them are the short-acting insulins, or the rapid-actings, because it continues, what it does is it continues what they call a basal rate. So it has a continuous infusion of insulin throughout the body to help maintain your blood sugar. When you eat, you calculate your carbs, you can increase that insulin, give yourself what they refer to as a bolus, so it will account for that rise in your blood sugar to maintain that normal blood sugar. You can also adjust it as necessary for exercise and those kind of things. There's the insertion device, which you're going to use with the infusion set. And then some of our patients, not all of them, use a continuous glucose monitor. Now this happens to be I sold this, I believe, from Medtronic, was the website that had the best graphic for this. Not everybody uses the CGM. However, the CGMs, Medtronic advertises theirs, it'll show you a glucose reading every 5 minutes in real time. So think about our diabetics in the past who had to stick their fingers 4 times, 5 times a day, checking their blood sugar, now trying to calculate your insulin. Well, now I've got an insulin pump that delivers my insulin constantly. I'm able to check my blood sugar every 5 minutes so I know where I am. For some of our unstable or brittle diabetics, this can be a life-changing device. These are very important for them. I recently ran a call on a patient who was hypoglycemic, who, when we got him, his insulin pump was actually off. It was depleted and it was turned off, and he had no idea. He had fallen asleep and he ran into some complications from that. So if you get the chance when you have these patients, especially if there's a diabetic emergency with them, take a look at the pump. It should pretty clearly tell you what the delivery rate is. The insulins, when they do the insulin, it is a standardized concentration for most of the insulins. It's 100 units per milliliter, and the vials are 3 ml, if I remember correctly, vials. They're pretty small. Some of the other insulins, though, they may get into concentrations of 300 units per ml when you start talking about some of the ultra long acting ones. So diabetic ketoacidosis, this is the big thing that we all learn other than hypoglycemia when we go to EMT and paramedic school. And we don't really think about it that much. We see our patients, they've got high blood sugar, okay, I'm going to go ahead and treat them, but I don't think about it. This affects insulin-dependent diabetic patients. These are also patients, as I mentioned earlier, my friends, the undiagnosed diabetics. There are insulin dependents with increased insulin needs, so infection. Anytime there's an infection in the body, it places an increased metabolic demand on the body. The body's really working. There's an increased need for insulin as part of this. Trauma, same thing. The stress of a traumatic event places a huge demand on the body, and if the body is injured, it's trying to heal itself with that increased metabolic demand. It requires increased insulin. And surgery. Surgery, again, you've got whether it was an elective surgery or an unplanned emergent surgery, you're placing a large demand on the body because of a process that occurred, traumatic or medical, and now you're trying to recover from that process. There's an increased demand. And we have patients that, let's be honest, they're just non-compliant. They may have insulin, they may take it sometimes, they may completely stop taking their insulin. So the basic pathophysiology, due to the lack of insulin, we get hyperglycemic, because remember, we need that insulin to get the glucose into the cells. So if we don't have that insulin, we have that glucose that just filters around, it circulates through our body. So the cells aren't able to use it. The cells are literally starving for the glucose, which it can't get. We have gluconeogenesis, so that is the production of sugar. Their body is trying to make sugar because it knows that it needs to get sugar into the cells aren't getting it. So we are already hyperglycemic. Now our body says, hey, I can fix this, I can make sugar, and starts trying to make sugar. Well, without the insulin, it doesn't go anywhere. So now our blood sugar continues to rise. Our sugar, once it gets to a certain point, will start spilling over into our urine, so glucoseuria. In the old days, when they diagnosed diabetes, and actually the first mentioned in medical text, diabetes was first mentioned in 81 or 82 AD in the Greeks, and it was defined as the melting of flesh and bone into urine. And that came back to the diabetic ketoacidosis because, again, they didn't have a lab in 81 AD. They couldn't test these things. So they would have patients who were average adult size who all of a sudden would just start peeing a lot. And as they started to pee and pee and pee, they would start to lose weight. And it was the melting of flesh and bone into urine. So the way to test that, actually, as you were learning your trade in that day, the new doctors would actually test the urine. If the urine was sweet, you were a diabetic, and that's how they diagnosed it. So we have this glucoseuria. We're spilling those sugars in. So glucose makes us pee. We know that. So now they're peeing this out. You also have an osmotic diuresis that occurs. You've got these big particles and you've got this fluid gradient. Remember, we want things to kind of be equal. When we have these large particles, it creates an unequal fluid gradient. Now we're peeing out more. So now we're losing lots of volume in these patients. And this results in significant dehydration. As a result, our body switches to a fat-based metabolism, which results in breaking down of fats. One of the byproducts of that is ketones. Now we have these ketones, and these byproducts are being created. As the ketones accumulate in our body, the kidneys are trying to excrete them. We're trying to get rid of them. We're trying to get rid of the sugar. But more ketones are being produced than what we can actually excrete. So now we get into a metabolic acidosis because we have a ketoacidosis. We have that increase in the ketones. This now results in a lot of problems. One, we start to get some central nervous system irritability. We're dehydrated. We have a stress response. I'm not getting sugar to my cells. My cells are starving. I'm losing volume rapidly. I'm now going to start dumping some epi into this and norepi. So I want to try and preserve what I have. Now my heart rate increases. My blood pressure, we're trying to maintain some of that volume. Ultimately, we'll slip into a coma with this uncorrected, and death is the ultimate outcome, uncorrected. We can actually see diabetic ketoacidosis with blood sugars as low as 300 in some patients. I've seen patients when I worked in the hospital that were on the low end of that. It's not always the super high numbers that we think about. So again, things that we may see. Altered mental status. Depending on when we get this patient, they may be altered. They may actually be unresponsive at that point. If there is an infectious process going on, we may see a fever. Also part of the metabolic process with our body, trying to recover from things, we may see a little bit of a fever effect. A lot of times if they have something going on, we may see nausea, vomiting before they actually get to that point. Kussmaul respirations. We learn about that in school and we don't always see it, but it's those rapid, deep respirations. They're very fast. They're in excess of 30 times a minute, rapid, deep. We're trying to correct that acidosis. So if you think back like to our capnography, if you throw capno on these patients, you're going to see capno, and they're rapid, they're deep, they're trying to blow it off because they're acidotic. Acetone. They tell you that you may smell acetone. Some people describe it as a fruity smell. Some people describe it as a smell of rotten fruit. It kind of depends, but up to 50% of the US population can't even smell the acetone. I, in my experiences, have never been able to smell acetone on patients, even when I knew that they were in ketoacidosis. They're going to have warm, dry skin. They're going to be tachycardic. Remember, we're having that epi release. Some of them will present with abdominal pain. I can think of several patients specifically I took care of that presented simply with abdominal pain and nausea, vomiting because of an infectious process that was going on, that stress release, everything's going on. And then we have the 3 Ps, the classics, the polydipsia, polyuria, and polyphagia. Polydipsia, they are drinking. They are drinking and they can't get enough. They're drinking everything that they can get their hands on. The polyuria, they are peeing everything out. The polyphagia, they have increased hunger. So when we talk about assessing these patients, when we talk about our diabetics, especially if their sugars are high, ask these 3 questions. Hey, have you had an increased thirst lately? Have you been peeing more than normal? And have you been eating more than normal? We're going to talk at the end, we're going to review our treatments right out of our protocol, so we're going to keep going here. Our type 2 diabetics, these are our adult, typically referred to as our adult onset or our non-insulin dependent diabetes. It accounts generally for 90 to 95% of all cases of diabetes. This is the most prevalent one that we're going to see. It's directly related, thought to be directly related to hereditary. However, obesity is also a large part. I'm probably going to be guilty of this myself. There's a decreased binding of insulin to cells. So the insulin, we just can't utilize that insulin and get to the cells. These can be treated though, however, dietary changes. There's some oral drugs that will increase our receptor effectiveness. But really, dietary change and exercise are the two biggest factors. There are patients that can manage their disease process even after diagnosis without going on drugs, simply through dietary changes and through exercise and weight loss. There's a less risk with this of fat-based metabolism. This becomes important because we're going to talk about a medical problem that's very hard to distinguish between DKA and the other medical problem we're going to talk about in just a minute. This is some of our most common oral hypoglycemics that we'll see out there. Most of you have seen these: the glimepiride, glipizide, glyburide, metformin. I can't even say that, so we're going to go with the easy one, the Avandia, the Actos, Januvia, and Onglyza. These are some of the most common. There are quite a few more out there, and there are actually some, these are all oral, there are actually some that are injectable also that you may see. If you don't recognize it, ask your patient, and again, I encourage you, go look up these meds. I will go home, write down a med, go home, look it up, and try and learn a little bit about it. So next time I see it on a call, I go, oh, hey, that's a diabetic med, I know that. Excuse me. So I said, kind of alluded, we're going to talk about another medical problem. Hyperosmolar, hyperglycemic, non-ketotic coma. HHNC, HHNK, depending on how you learned it. Some people learned it as HONK. I said earlier that there's less risk of fat-based metabolism. With DKA and HHNK, they're very similar in symptoms, so it's very hard for EMS providers to distinguish, so they're treated pretty much the same by us. It affects the non-insulin dependent diabetic patients. Primarily, it affects our elderly populations. Our mortality rates, however, 20%, as high as 20%, because there's lack of early symptoms. Especially think about our elderly populations. They're at higher risk. They don't have the reserves that young, healthy patients do. The hyperglycemia is typically greater than that of DKA. You may see sugars in excess of 1,000. Now, our meters, we know only go up to 500, so we won't see that. However, in the hospital, when they draw labs, you can see sugars 1,500 or greater, which is a pretty significant number when you see that. And again, physiologic stress. Infection is the #1 cause of HHNC. Dialysis can cause this also, and high osmolarity feeding supplements. Again, when I looked up a little bit of the pathophysiology of these, just to remind myself, it has to go back to that fluid gradient. Having those particles, which creates a fluid imbalance, leads to this process. So essentially, there's a sustained hyperglycemia. These patients are hyperglycemic. Glucose, again, continues to spill into the urine. We get that osmotic diuresis and the dehydration. Sounds pretty familiar. Sounds like the DKA we just talked about. However, these patients still have some insulin activity that's present. Not a lot, but some. So it prevents the production of ketones. The body doesn't have to break down fats because that ketone is still there. So there's just enough insulin to prevent the fat breakdown, but we have that decreased insulin. Our blood sugars continue to rise. The sugar spills over into the urine. They start to diurese, they become dehydrated, ultimately resulting in coma and death in these patients. So again, our altered mental status up to unresponsive, that can be anything in between. Seizures with these patients, potentially. And we can see seizures with other patients. Anytime your blood sugar gets that high, you start to have some CNS irritability. It's possible. I can't think of a case that I personally have seen. I know, though, in reading some of the literature, that it is possible. Again, warm, dry skin, they're tachycardic. They have orthostatic hypertension. And again, the 3 Ps, polydipsia, polyuria, polyphagia. Switching gears, we talked about high blood sugars and our different types of diabetes. Hypoglycemia. We run these calls every day. These are our treat and streets. We can treat them and we can get them out again. Essentially, there's too much insulin or oral medication in these patients. It may be, though, there's too little food intake. So the top one, we have our patient who takes their insulin shot, they don't eat. Combination of the two. And then they become hypoglycemic because the insulin moves all the available glucose into the cells. There's no more. It's not enough. Their blood sugar plummets. We get called. Vomiting and diarrhea, you have that fluid loss that can occur. Excessive activity in relation to the fluid or insulin supply. So again, if they're not watching their sugars, they're really exerting themselves, they can put themselves in a situation where they become hypoglycemic. And then the great confuser of everything, alcohol. Alcohol can affect our body's ability to utilize the insulin and the sugar. That's why we carry medication thiamine on our trucks for can be used with some of these patients. So we have the increased insulin or inadequate sugar intake, resulting in a low blood sugar. Our body tries to naturally compensate. We try and activate those glycogen stores in the liver. The glycogen is converted to glucose, hoping to raise that sugar. It may not work. We are now placed under severe metabolic stress within the body. We have that epi-norepi release. That's where we get the tachycardia from, the diaphoresis. However, my brain is starved for sugar. Remember, the brain needs two things to run. It needs glucose and it needs oxygen. Without either of those, it's not going to work. Again, without those, we can have seizures as a result. And ultimately, when the sugar drops too low, they're going to result in coma, and untreated can result in death. So our signs and symptoms, which we're pretty familiar with, the altered LOC. They may be just mildly altered. I was called once for a sick person. Very nondescript complaint. 80-year-old male World War II pilot, flew bombers over Europe, and just didn't feel right. So we did the EKG. The EKG's normal. Checked all his blood work. Blood work's fine. He has no significant history that we're worried at. Last minute says, hey, let's check his sugar. Let's just see where he is. His sugar, and this is an 88-year-old, was in the 20s, and he was talking to me, alert-oriented, not diaphoretic, not presenting like your typical diabetic patient. Headache, irritability, seizures, slurred speech. Slurred speech, that's a dangerous one. We assume, and it's caught several people by surprise, slurred speech, we assume, oh, hey, they're drunk. This is where several fire and EMS departments have actually entered into law, been sued, because they assume that the patient is drunk because they have slurred speech. They write it off, it may be at night, and slurred speech actually was because they were hypoglycemic. They may be pale and cool. We typically see that. Sometimes they're profusely diaphoretic. Tachypnic and tachycardic, part of that stress response. Again, I'm trying to work through that. So those are all the signs and symptoms that we may see. So let's go through our protocol. This is straight out of our protocol book. We have our universal patient care. We're going to check our sugar to determine if it is symptomatic or not. Most texts will put a sugar between 70 and 120. It depends on what textbook you're using. We use 60 with symptoms as our benchmark. So if we have 60 with symptoms, are they able to swallow? It's the first thing we want to know. If they can swallow, hey, great, we carry oral glucose. Let's give them a pack of oral glucose. Let's see if that comes up. We give them the 15 grams. We have to give them 15 minutes. Remember, it takes time when we're taking it orally, so it's actually got to work through the body. It's not going to work as fast as an IM med or an IV med. Give it some time to work. Did our sugar come up? No. Then we need to, is it less than 60? Then we need to go under our IV procedure. If we do get it up, then we can reassess our patient and disposition from there. However, if we can't get it up, or if they're not able to swallow because they're unresponsive, we need to go ahead and start our IV, do our D10 that we're using now. So we will titrate that to get an increase in their blood sugar. It's a great drug, everybody's seen it. People still get amazed when you get a D10 and the patient suddenly just wakes up and they go from pouring sweat to dry and going, hey, what's happened, why are you here? Oh, my blood sugar dropped again. Reassess those patients. After that. Now, if we can't get an IV established after 3 attempts, we can do that glucagon, that 1 milligram. Again, that does take a bit of time for that to work, but that 1 milligram will start to bring the sugar up. It's not going to have the dramatic effect like we see with our D10. Reassess those patients. If not, then we can repeat our D10 and then transport them to the hospital. We ultimately, I know that we're pretty quick to treat and treat these patients, but ultimately we need to try and figure out why did their blood sugar drop, because a lot of times there may be something going on underlying, a physiologic thing. There may be an infection going on. There may be some metabolic stresses, and we need to try and figure that out. So those are things that are important to ask as you're taking care of these patients. Hey, have you been sick recently? Have you had a fever? Have you had any recent injuries, significant injuries? Have you had any recent surgeries? We want to figure that out. Now, if our sugar is greater than 300, we're going to start an IV on them. There's not a whole lot that we can do in the field. We are going to start some fluid hydration. Remember, these patients lose a lot of volume. So sugar's greater than 300, we're going to start with a bolus of 500. And then once that bolus is in, we're going to put those patients on the pump at a liter an hour and transport them appropriately. I said earlier, if we suspect that our patients have alcoholism, because alcohol confounds our clinical picture, it doesn't allow the body to use the sugar and the insulin appropriately. Thiamine, we can give 100 milligrams thiamine to those patients. It'll help. That also is great with patients that are on chemotherapy because, again, there's some metabolic changes that occur with that. We use 100 milligrams IV. That is perfect, and that's what we should do. Some systems will actually split that 50 IM, 50 IV. You'll get the immediate effect, and then you get a little bit delayed effect with that. A diabetic patient that we really don't talk about that often, that we don't think about really, is our gestational diabetics. These are patients that are obviously pregnant, gestational. It affects about 10% of all pregnancies. I don't have a total count of the number of pregnancies within the United States, so I couldn't get a firm number. They're not exactly sure why this occurs. There are some thoughts, but we're not sure. Ultimately, though, the mother's body is unable to produce or use the amount of insulin that's required. So they just can't produce that. The insulin, they can also develop insulin resistance within the body. So the body it's resistant to the sugar, to that binding and uptake in the cells. They may require 3 times the amount of the normal insulin to actually get therapeutic effect with this. It resolves typically after delivery of the fetus. However, 50% of women will later develop non-insulin dependent diabetes. So that is something that you really need to watch. It's actually tested for after 12 weeks, between 12 and 24 weeks during the pregnancies when they'll actually test for that. So the risk factors, any race other than Caucasian. They literally in the text listed every race other than Caucasian. Advanced maternal age. I realize that 25 is not that old, but that's considered to be advanced maternal age. That puts you at higher risk. Obesity, family history of the non-insulin dependent diabetes, polycystic ovarian syndrome because you have insulin resistance with that, any history of previous gestational diabetes, and delivery of a fetus weighing greater than 9 pounds. All increase your risk for gestational diabetes. Now, this comes with some complications. As you have this gestational diabetes, you're trying to watch your weight, you're trying to control your sugars through this. However, in poorly controlled gestational diabetes, there is hyperglycemia. You've got that extra sugar that's floating around. The fetus loves that, and it eats that up. It basically feeds the baby, which though results in increased fetal growth. So you will have large babies that occur. This presents, so that's a complication in and of itself. Now, as you have this large fetus, this may require a C-section. There are certain risks with C-section. If they do attempt to deliver vaginally, there's some documentation of increased risk of some nerve injuries within the shoulder. If you think how the baby presents down through the birth canal, there's that increased risk because you have this large baby that's moving down and there's some compression that occurs. These patients are also at risk for preeclampsia, another medical problem that we don't see that often, but again, just as life-threatening potentially. And then hypoglycemia. After the baby is born, they've lived in that hyperglycemic environment for a long time. That's what their body's used to. So once the fetus is born, we actually now have hypoglycemia that may occur within the fetus. So that's something that we really need to watch when they deliver the baby. If you know that it's a high-risk baby, maybe we're checking sugar just to see where they are. Some of our long-term complications of diabetes, again, it's a very sad disease in a lot of ways because we have cardiovascular effects. We have strokes that occur. Hypertension we know is a chronic problem with this. We have neuropathy, so we have loss of sensation within the feet. So even small wounds you may not realize, and if you think particularly with our older patients, they may not be as limber as we are. So they stub their toe, they step on something, they're not able to examine their feet very well. It may be on the bottom of the foot. Now they develop a wound. That wound continues to grow because they're diabetic. It doesn't heal as quickly, and it leads to underlying infections. So that places increased stress on the body. Ultimately, these are the patients that we see that have to have amputations. Sometimes starts off with toes, then the foot, then up below the knee, and then above the knee. And then these, we may have vision loss. We've got glaucoma that occurs because we have these large glucose particles that occur. The fluid changes that can occur with this can result in cataracts and vision loss. And then renal failure. Again, those large glucose particles get lodged in the kidneys. It creates a lot of complications. That's why a lot of times these patients are also on dialysis. Many of those, however, can be delayed or prevented with lifestyle change. That's the hardest thing, is changing your lifestyle to adjust to this disease process. Something that we don't think about as much, pancreatitis. So we talked about the pancreas, all these medical problems that we have from the pancreas, but we can actually get inflammation of the pancreas. It can be acute versus chronic. They actually break this down. 25% of patients who experience acute pancreatitis are going to experience a recurrent episode within the next year. It affects men greater than women. African Americans are at higher risk. It does carry a significant mortality of 2 to 9%. There's a lot of complications that can occur from this. You can get some hemorrhage that can occur. You can get some damage that releases some of the enzymes. Those enzymes can actually do what they call autodigestation. So it will actually start to break down the pancreas itself potentially. Most cases are going to be our acute cases. Biliary obstruction, I talked about that bile duct that goes to the backside of the pancreas. You can get a stone that lodges in there, which creates a lot of inflammation. You have the backup of those products, that bile that helps us to break down, to help us as part of the digestive process. Alcohol is another very significant contributing factor. And toxins, which toxins can include medications. Some medications can be toxic in certain quantities. Elevated triglycerides also in the acute onset, in the acute pancreatitis, can contribute. In the chronic pancreatitis, heavy alcohol use is the most common factor. There are also autoimmune diseases and familial history that affects this. Signs and symptoms that we see. Belly pain is very difficult for us in EMS to be able to diagnose exactly what's wrong. There's a lot of organs. The signs and symptoms aren't always clear. Maybe they have referred pain, so we're not always clear. But one that we should think about sometimes, especially when we have epigastric or left upper quadrant abdominal pain with distension and tenderness, consider the possibility of pancreatitis. Ask about the history of pancreatitis. About 30% of the population may have back pain. Most of the time they will have vomiting. In my experiences working in the hospital, I can think of several patients that we knew had a history of pancreatitis. Their presenting complaint was nausea, vomiting, and left upper quadrant pain. It was a classic presentation for them. They also, the one I think of most, also happened to be African American. That's that risk factor that he had. We knew when we saw him that that's what he was going to be coming in for. In the chronic population with that chronic pancreatitis, they may have oily stools, they may have clay-colored stools. And then dehydration. Again, these people, when they're vomiting continuously, and they lose a lot of volume through that vomiting. Our management for these patients is going to be primarily symptomatic management. We're going to treat the pain as we can, IV fluids, put them in a position of comfort, and transport to the appropriate hospital. That's going to conclude this morning's lecture for endocrinological emergencies. If you guys have any questions, if you see me out and about, I'm happy to answer questions, or you can shoot me an email. Thanks, you guys have a good day and be safe.